Good morning. My name is Julie Hawkins, events manager here at Winship Cancer Institute. Thank you for joining us this morning for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the login information will be found in the chat feature on the bottom of your screen. If you have any issues with this webinar or the CME login, please send me an email or drop me a note via the chat feature. This morning, we are excited to welcome Dr. Laurie McKenzie. Dr. McKenzie is an associate professor in the Department of Gynecologic Oncology and Reproductive Medicine at MD Anderson Cancer Center. She also holds a joint appointment in the Division of Reproductive Endocrinology and Infertility at Baylor College of Medicine. Following her fellowship training at Baylor, Dr. McKenzie spent 11 years in private practice in Houston, Texas, providing comprehensive fertility care. She started the nonprofit Hope in 2010, the first Oncofertility program in Houston. She also participated in the fertility care of the first child born in Texas conceived with cryopreserved oocytes. Dr. McKenzie then joined the faculty at Emory University in Atlanta, Georgia to focus on fertility preservation for individuals diagnosed with cancer and served as the director of Oncofertility. She returned to Houston to join the Oncofertility team at MD Anderson to expand both clinical care and fertility-related research. Dr. McKenzie is a fellow of the American College of Obstetricians and Gynecologists and a member of the American Society for Reproductive Medicine and former REI chair of ACOG's CRYOPRESERVATION committee. Dr. McKenzie has authored and co-authored numerous articles in peer-reviewed journals and serves as a reviewer for the Journal of Assisted Reproduction and Genetics and Fertility and Sterility. She's a board examiner and speaker for the American Board of Obstetrics and Gynecology and serves on multiple national committees. Her clinical practice at MD Anderson Cancer Center encompasses fertility counseling prior to cancer treatment, as well as family building services for men and women whose reproductive potential may have been impacted by cancer treatment. Welcome, Dr. McKenzie.
Great, thank you, Julie. I really appreciate the invitation to speak this morning and certainly wish I could be there in person to see everybody. I'll make certain that I leave time for questions, and I'm an hour earlier, so my clinic doesn't start until a little later, so certainly can take questions offline as well, just in the interest of time. So let's go ahead and get started. I have no relevant financial relationships to disclose. And what I'm going to be talking about this morning is I'll be first defining the field of oncofertility and the rationale for this. So why am I taking an hour of your time this morning to talk about oncofertility? I'll be going over this, and hopefully by the end of this hour, perhaps you'll have a little bit different perspective in terms of the importance for patients and their potential families. I'll review what the fertility preservation options are and touch briefly on some of the safety and research implications. And also, lastly, I'll just briefly go over some mechanisms for implementation at your institution in terms of outreach for fertility preservation. So let's start first with what is oncofertility. This serves as a bridge between oncology and reproductive medicine designed to expand the reproductive options for those affected by cancer. And why is this important? Well, for several reasons, but if we just look at the population diagnosed with cancer, just under 10% in the US are under age 45. And depending on which metrics you're assessing, it can be as high as 12%. 1 out of 47 women will be diagnosed with some type of invasive cancer by age 40. And approximately 10% of cases of breast cancer occur in women under age 45. So if we look at, So if we look at the types of cancers that are affecting our reproductive cohort, breast cancer certainly is number 1 on that list. And if we look at the age group specifically 15 to 39, thyroid cancer, leukemia, lymphoma, melanoma, and colorectal cancer. I will say the vast majority of the referrals that I see in my clinical practice are breast cancer and hematologic malignancies. If we stratify this a little further, if we break this down into further subsets, you can kind of see where these different malignancies are sitting based on patient age. But again, breast is predominantly the number one, particularly in the women aged 30 and older. And so if we look at how we're doing in terms of survival, we're doing well. And that's why, happily, these survivorship issues are becoming increasingly important. 80% and above of children diagnosed with cancer become long-term cancer survivors. And if we look at the 5-year survival rate for women with invasive breast cancer, we're doing well. It's approximately 90%. And if we look at patients diagnosed with cancer, they do have a strong desire to have a biological child, as opposed to consideration of other options such as adoption or egg donation. And this is really a fundamental tenet of survivorship care. So how are we doing in terms of addressing these concerns for our patients, the reproductive impact of their cancer treatment? You know, in 2011, a large survey of oncologists demonstrated that greater than 50% rarely refer their reproductive aged patients to reproductive endocrinologists. And even gynecologic oncologists are not doing much better. Only 37% of them reviewed reproductive goals with their patients prior to treatment. So we have a long way to go in terms of improving our counseling for these patients. And ASCO has certainly understood that this is important to patients. They realize that patients with cancer are interested in discussing fertility preservation. They recommend that healthcare providers refer patients who express an interest in fertility preservation to reproductive specialists, and that this counseling, this conversation should be discussed as early as possible prior to treatment start. And they feel strongly enough about this that this is now one of their quality reporting measures. It's QOPI measure number 33, in which patients should be provided with verbal and written or electronic information as part of an educational process prior to the first administration of treatment, and this should be documented in the treatment plan. And specifically, the potential long and short-term side effects of therapy, including the infertility risk for the appropriate patients, should be discussed. And so if we look at what are the primary determinants of the impact of cancer treatment on their fertility, there's multiple variables that we need to take into account: the age of the patient, the type of agents that are utilized, the dose of the medication that's being administered, the number of cycles, and certainly the patient's baseline fertility status. And we'll talk a little bit more about that shortly. If we look only at the onset or resumption of menses following someone's cancer treatment, that does appear to be quite insufficient to predict what their future fertility is going to be. That childhood cancer survivors who continue to have regular menses, even more than 5 years after their cancer diagnosis, still had a risk of developing premature menopause or premature ovarian insufficiency that was 13-fold higher than their siblings. So the menstrual cycle is not a great metric to use in terms of determining if somebody's fertility has been compromised after chemotherapy exposure, for example. And unfortunately, most of the studies are using resumption of menses as the primary benchmark for following these patients. And again, we can talk about that a little bit later as well. If you compare a cancer survivor to a aged matched sibling, her fertility is reduced by about 50% compared to a family member. And so this kind of gives you a little bit of an overview in terms of just looking at women and their fertility. And this is something I just want to go over, just a little background information in terms of just egg biology or reproductive aging. I essentially peaked, reproductively speaking, at about 20 weeks in utero, and I've been declining ever since. So the most number of eggs that I'm ever going to have is while I was even prior to birth. And over the span of my life, I will ovulate approximately 500 eggs. And that cohort of eggs does not regenerate. I am born with a finite number of oocytes, and that number declines over time. And so what that means for us clinically, and I think this underscores the age-related decline that we see in women very well. This is data that's taken from the CDC and SART for all individuals that went through IVF in the year 2016. And this is maternal age on this axis, and this is live birth pregnancy rate, miscarriage rate on this axis. So you can see there's a very significant decline, and this is just for all comers with IVF, not specifically cancer patients. And you can see at age 38, there's a significant drop in a woman's fertility, and this also correlates with the time that the miscarriage rates increase significantly. So all these celebrities that you're hearing about that are having pregnancies at age 45, well, it's either that they froze eggs when they were much younger or they're using donor eggs. And why this is important in our context is if I have a woman that has been diagnosed, for example, with breast cancer, and she's 45 years old, and she's interested in fertility preservation, well, that's, with her own eggs, that's really not a realistic goal for her. And so I use a lot of this type of information in terms of my counseling of patients. For example, if I have somebody that has been diagnosed with an early endometrial cancer and she's contemplating conservative management of that endometrial cancer and she's 46, well, I think that's a somewhat unrealistic objective for her unless she was entertaining use of donor oocytes. And so there are ways to measure somebody's ovarian reserve above and beyond just age. There are several tests that can be obtained on a patient. And the two that are used most commonly now is the AMH and the antral follicle count. AMH, anti-Müllerian hormone, is a hormone that's produced from the granulosa cells that surround the egg. And the amount of AMH that's being secreted correlates very well with the number of oocytes and even the quality potentially of those oocytes. So the higher the AMH, the better. The antral follicle count is a sonographic measurement where you actually count the number of resting follicles, and that correlates with the number of oocytes a woman has in her ovarian reserve. And so these are two tests that we order quite frequently on patients to get a sense of what somebody's baseline ovarian reserve is. I also use these values to track patients after chemotherapy. So if I have a baseline assessment of a woman's AMH and antral follicle count, then I can check these metrics a year, 2 years, 3 years out after chemotherapy to try to track and determine what the rate of fertility decline has been. And this is especially helpful if somebody's on endocrine therapy and they're not having regular menses. FSH and estradiol levels would not be accurate in that context, as would an inhibin B. So another comment I'd like to make is it takes a while for an egg to grow. And why this is important clinically is if I have somebody that's been exposed to chemotherapy within the past year, there could be potential teratogenic effects or damage to the oocyte. A lot of people think that an egg takes 2 weeks to grow because that's, the typical follicular phase of a menstrual cycle, but that's actually not the case. The development of a primordial follicle to an ovulatory follicle can take even up to a year. And so any potential gonatotoxic agent that's been exposed during roughly a year's time, in theory, could have some impact in terms of the health and the quality of that oocyte. Talking about specific agents, this is a very kind of crude overview in terms of what the different chemotherapy regimens look like in terms of their risk for amenorrhea. Again, not the best benchmark, but really, unfortunately, where most of the data is in terms of looking at chemotherapy impact with fertility. And again, I say this is a very crude overview. There's certainly lots of variation in this. I'm seeing clinically women that are getting more dose-dense regimens, especially for breast cancer, have much higher rates of amenorrhea than what's reported here. And again, that's something that we can talk about maybe in the Q&A or if we want to delve into that a little further. So how is it, or what is the mechanism that these chemotherapeutic agents are affecting fertility? And there's really two primary theories that have been proposed, and they're a bit in conflict with one another, but I'd like to just go over the pathophysiology just a bit. You know, any type of chemotherapy agent is thought to induce, well, specific agents are thought to induce some of the DNA breaks in these primordial follicles. And so it's causing a direct toxic exposure to the resting follicles, and they undergo apoptosis and death. So you're damaging this primordial follicular pool of these early resting oocytes. This is kind of direct DNA damage to the resting eggs. The other theory is a little bit in conflict with that. It's basically the thought is that if you have growing follicles, there's something in those growing follicles that's inhibiting the recruitment of these resting follicles, that there's some suppressive factors that are produced that maintain the dormancy of these primordial follicles. Exposure to chemotherapy would cause those growing follicles to undergo apoptosis, and then you get recruitment, a massive recruitment of these resting primordial follicles that then grow, develop, and undergo apoptosis, causing that reservoir of these resting follicles to burn out. So it certainly could be a combination of both factors, but really these mechanisms are poorly understood, even with the typical alkylating agents. And there's even less data with some of these newer agents, such as the tyrosine kinase inhibitors, monoclonal antibodies. We really have very little data in terms of how some of these newer agents are affecting fertility. And if you think about it logistically, you know, there's a normal immune suppression that occurs with pregnancy, right? I mean, that fetus is essentially 50% foreign. So there's a normal immune modulation that takes place in pregnancy. And so if you're disrupting these immune mechanisms with some of these immune regulatory drugs, the checkpoint inhibitors, how could that affect fertility? And I think it's a really interesting area for exploration and certainly something I'm very interested in. So let's talk about what the fertility preservation options are. And I'm going to go through this fairly briefly just in the interest of time. So we'll walk through gamete cryopreservation, some of the surgical options very briefly, and then hormone manipulation. So if we think about gamete freezing, freezing eggs, sperm, embryos, this is not a new concept. The first child that was conceived via cryopreserved sperm was delivered in 1953. And very interesting, just as an aside, that pregnancy was not actually reported publicly until almost a decade later, simply because there was such a negative environment at the time related to artificial insemination with donor sperm. In fact, the Cook County Supreme Court had ruled in 1953 that using donor sperm insemination was contrary to public policy and good morality, which I think is just really fascinating from a historical standpoint. The first child that was conceived via cryopreserved embryos was in 1984, and then 2 years later was the first child that was conceived and delivered via frozen eggs. But then there was a big lag in terms of the use of frozen eggs, and we'll talk a little bit about why that is, versus freezing embryos. The largest series looks at over 900 births from cryopreserved oocytes and shows no increased malformation risk in the offspring. And there does tend to be less issues from a psychosocial standpoint freezing oocytes as opposed to freezing embryos. If somebody ultimately needed to discard embryos versus discarding oocytes, it seems certainly to be a lot less sensitivity associated with the oocytes. But oocytes historically have been very difficult to freeze and thaw successfully. And the two primary methods that we use to freeze gametes is either this traditional slow freeze process or vitrification, which is a very rapid freezing, which involves essentially an instantaneous phase change. And slow freezing works very well for embryos and for sperm, but it does not work well for eggs. And so vitrification, this is just kind of a schematic showing the difference in terms of the two freezing techniques. And it wasn't until vitrification that was being used widely that we were able to get good survival with oocytes as opposed to embryos and sperm. And so now egg freezing seems to be very much the standard of care. And we can talk about maybe what would be some advantages or disadvantages of freezing eggs versus embryos. So what does a process to freeze eggs look like? If I have a woman that's interested in freezing eggs, we need to do this quickly. What's typically involved is gonadotropin stimulation. Recombinant FSH and LH are administered via injection for a period of time anywhere from 8 to 12 days. We don't want her to ovulate those eggs that she's growing. So there is a mechanism in which we downregulate the pituitary's natural LH surge. And then we induce the final maturation of those oocytes. It loosens the gap junctions from the follicles and allows us to harvest those eggs. And we want many eggs to grow. You know, typically a woman develops 1 egg a month. We want 12, 18, 20 oocytes to grow in that 2-week period of time. And this just kind of gives you an overview of what are the drugs that we're using to accomplish this. The recombinant FSH that we use is Gonal F, Follistim, Menopur is FSH and LH. We can even use human menopausal gonadotropin. That's not used too much anymore. And then we typically will use an antagonist, a GnRH antagonist or a GnRH agonist, Lupron typically, to prevent early ovulation of those eggs. And then HCG or leuprolide can be used to induce the final maturation of the eggs. So again, this whole process really from start to finish should be no more than 14 days. And if we look at specifically the estrogen levels during this time, so during these 2 weeks, what's happening to the estrogen levels? I have this slide included here, especially for patients with hormone-sensitive tumors, particularly breast cancer, for example. You know, these estrogen levels with a typical IVF stimulation go up exceedingly high, several thousand. Normally with a typical ovulatory cycle, somebody's not on any medications at all. Normally we reach about 200 picograms per ml of estrogen at a maximum during a regular menstrual cycle. So you can see this is really super physiologic. But there are ways, typically with letrozole administration, that we can keep that estradiol level markedly low compared to what a traditional IVF or ovarian stimulation would look like. And so that's pretty much now standard of care for anybody with an estrogen responsive tumor. So letrozole is one of the newer modifications that's been used for ovarian stimulation in breast cancer patients, and also the addition of what's called a random cycle start. Used to be we had to wait for a menstrual cycle to begin before we would stimulate somebody's oocytes. And there's good data to say that you can start that stimulation at any time in a menstrual cycle, and it does not affect the yield of oocytes, or certainly not dramatically. And so this helps facilitate a quick start for their ovarian stimulation and helps avoid any further delay for these patients in starting chemotherapy. The process of aspirating the oocytes, it's a vaginal procedure. It takes me about 20 to 30 minutes. It's performed under conscious sedation, propofol Versed, a little bit of fentanyl. and the patient goes home usually about 2 hours later. The follicles are entered with a very long but small needle, and then I suction out that follicular fluid. The fluid contains the oocyte that's passed off to the embryologist. They'll identify the oocyte, either fertilize that egg or and then freeze as embryos, or we would freeze as oocytes. Conventional fertilization can be used where you just put the sperm at a set concentration as an overlay on top of those oocytes, and you just let them fertilize those eggs on their own. The other option, which is being used increasingly more often, I'd say greater than 90% of IVF cycles done in the United States are performed with ICSI, where you actually select a single sperm and inject it into the oocyte. And we'll see if this video works. Yes, and here's a video. This is a human oocyte, and this is the injection pipette holding the sperm. So you can really appreciate the size difference. And now they're suctioning out some of the ooplasm with that sperm, and then they'll re-inject the sperm with that ooplasm. This is a holding pipette. This is the zona pellucida, or the shell around the oocyte. And you can see that sperm here, very small, being injected into the oocyte. And this has been performed quite regularly since the early 90s. If the oocyte is fertilized, we then score the embryo. There's not a great scoring system for oocytes, but with embryos, there's a very well standardized scoring system that we use. We look at the growth rate and the growth pattern of that oocyte. And this is what a human embryo looks like after 5 days of growth. The trophoectoderm is the cells around the periphery, and that's what leads to the placental cell line. And this clump here in the middle, this is the inner cell mass, which leads to the embryo itself. And there's good data to support growing embryos to day 5, helps improve selection of the embryo and helps improve live birth rates if you are transferring a day 5 embryo as opposed to a day 3, an 8-cell embryo. This would be a day 3 embryo. This is a day 4 embryo, a morula, and again, a day 5 or blastocyst that you're seeing here. Pre-implantation genetic testing is being done increasingly more, and this is to look for genetic abnormalities in the embryo itself. This is particularly relevant for individuals that have a hereditary cancer syndrome. And so if we can identify if somebody has a BRCA mutation, for example, then we would be able to test for that mutation in the embryo and subsequently avoid transferring that embryo in a future IVF cycle. This is a video showing what that embryo biopsy looks like. This is a day 4 embryo, and this is a laser sighting that's creating about a 20 micron perforation in the zona pellucida of that embryo. And then some of the placental cells will herniate out of that embryo, and those herniated cells will be biopsied and submitted for analysis. Typically it takes about 2 weeks to get those results back, so we need to freeze the embryo again in terms of getting those test results before we know if that embryo is affected with that mutation or not. So let's talk just briefly about ovarian tissue cryopreservation. I could have a lecture, a standalone lecture on this topic alone, but over 130 live births with freezing the ovarian tissue. And really, this is not typically the whole ovary. There's an oophorectomy is performed, but then strips of that ovary are cryopreserved and then subsequently can be retransplanted into the patient after she's completed chemotherapy. And this is proposed for individuals that haven't hit puberty yet, where egg freezing would not be an option. I can't freeze eggs unless somebody has gone through puberty, or if somebody doesn't have the luxury of a 2-week delay. For example, if I have somebody with an inflammatory breast cancer, a very aggressive tumor, we don't even want to delay the start of treatment by a 2-week time frame. So ovarian tissue freezing would be an option for that individual. The experimental label was removed just earlier this year, and there certainly are some concerns, especially metastatic leukemic cells have been identified in some of the cryopreserved ovarian tissue, so that would not be tissue that I would want to retransplant into a patient. There have been some cases where PCR analysis has been performed to see if there was, if the tissue was devoid of any leukemic cells and subsequently retransplanted back, but I really think that that's, well, certainly not standard of care and not something I would be comfortable with, despite there being some isolated reports of that. There's no guarantee that that tissue is going to survive the thaw or survive retransplantation. So this is really reserved for individuals where there's not the option of embryo or oocyte cryopreservation. Some surgical considerations: if we have patients that have a very, very early cervical cancer, conservative surgical approaches could be considered. Patients with early, I would say stage 1, grade 1 epithelial or borderline germ cell tumors may be considered for more conservative surgical intervention. Same thing with endometrial cancer. We're seeing more and more patients elect for medical intervention with early endometrioids without any evidence of myometrial invasion. Ovarian transposition is another option for patients, especially if they're going to be exposed to pelvic XRT. And so that's a way of repositioning the ovaries outside of the radiation field prior to their radiation exposure. The issue with this is, and there's several, one is there still can be some scatter effect to the transposed ovaries from the radiation. The ovaries can actually migrate back into their normal anatomic location even after oophoropexy. And once you transpose the ovaries, it makes them much more difficult to access if somebody subsequently is having to go through fertility treatment. So instead of having a vaginal egg extraction, you may ultimately end up having to do a laparoscopy in those patients, or even potentially a laparotomy to successfully access those oocytes that have been transposed. There also seems to be some vascular compromise of the ovarian pedicle during the time of transposition. And so what you're probably gleaning from this is I'm not a big fan of ovarian transposition, and I would say even in the last 2 years, I have performed 0 transpositions, but it is an option, and in certain unique circumstances, it's something that I'll discuss with a patient, but I'm not aggressive about moving forward with ovarian transposition. Ovarian suppression has been proposed, and this is a way to try to induce a quiescent state to the ovary, hopefully to make it a little more resistant to any of the gonadotoxic chemotherapy effects. But it's really a bit controversial whether this works or not. There's some very good, well-designed studies that show there is some evidence of fertility protection if I put somebody on Lupron or Zoladex during their chemotherapy. And then there's also well-designed studies that show just the opposite. And so even as recently as 2018, ASCO guidelines have stated that the effectiveness of ovarian suppression during chemotherapy still has not been resolved. But there's very little drawback overall in terms of suppressing the ovaries during chemotherapy. And then it can also offer some benefit in terms of menstrual regulation, especially for patients that are going to be profoundly thrombocytopenic during their chemotherapy. It's in many instances helpful to have their menses arrest during that time. Often there'll be a little bit of a flare effect for about 2 to 4 weeks after administration, where you may see some irregular bleeding and increased vaginal bleeding. But typically that goes away once the ovaries are suppressed. I'm interested in looking at, instead of Lupron and Zoladex, an antagonist, a direct antagonist of GnRH that would induce a suppression much more quickly within a few days as opposed to a few weeks. And so that's something that I'm working on currently. From a safety standpoint, what you know, what are the concerns? Well, is pregnancy safe in these survivors? And is the exposure to the fertility medications? You know, if I have somebody go through fertility preservation, is that going to be to her detriment, particularly if she has a hormonally responsive tumor? And so some data we can say is very clear, and that's looking at, in terms of children of cancer survivors, this is a very nice study that looked at over 5,000 children that were born to cancer survivors, both men and women, and it showed that they did not have any significantly increased risk for any congenital anomalies. So that's one thing we can kind of cross off the list pretty easily, that there doesn't seem to be any increased risk to their children. A couple points I would like to make, you know, is a couple exceptions to this would be in terms of radiation exposure. There seems to be very much a timing hypothesis that women exposed to radiation after puberty have a larger uterus and have a better likelihood of successfully giving birth, as opposed to somebody that was exposed pre-pubertally to uterine radiation. And so very much the age of the individual seems to correlate with the safety of her having a successful pregnancy after radiotherapy exposure. Even doses as low as 1 to 2.5 gray prior to menarche is associated with a significant increase in the risk of stillbirth and neonatal deaths. And there are some ways that I can assess the uterus to see if it's going to respond to estrogen. Can I expose her to estrogen and see if the uterus is going to increase in size? But still, these patients need to be counseled very carefully if they've had pelvic radiation. And in many cases, I do consider this a contraindication for that individual carrying a pregnancy. And getting your MFM, maternal fetal medicine colleagues involved is crucial for these patients. Another consideration I'd like to throw out there in terms of safety is the cumulative dosing as it relates to cardiotoxicity. Remember, cardiac output is 50% above pre-pregnancy levels by mid-gestation. So there is a significant stress that's placed on the heart in terms of just pregnancy itself. And a lot of people don't realize, especially if they're childhood cancer survivors, they are not, I'm surprised at how many adults do not recall what their chemotherapy regimen was when they were treated as a child. And so they don't know if what type of drugs that were used, if they were potentially cardiotoxic. And I think there was a lot less attention given to these patients in terms of obtaining baseline echo studies prior to consideration of pregnancy. I was involved with the care of a patient that was kind of just that scenario. She was an adult, did not recall what her chemotherapy regimen was. She ended up going through IVF, conceived twins, and was hospitalized with an ejection fraction of less than 30 during the pregnancy. And it was really just a very unfortunate situation. This was not a patient of mine, meaning not a fertility patient of mine, but I was brought in later to help manage her in terms of counseling. And fortunately, she survived, the children survived. She declined termination, which had been offered to her, and was just a really very impressive situation. So that's certainly something, again, we don't want to take lightly. Make sure they've had adequate cardiac assessment prior to considering embarking on a future pregnancy. And if we look at specifically breast cancer patients, we don't have a lot of long-term data in terms of patients that froze eggs and were exposed to fertility medications for 2 weeks in terms of their long-term survival. Most of the studies, their longest duration is between 5 and 8 years of follow-up. But fortunately, that follow-up does seem to show that they don't have any increased recurrence rates, that the 2 weeks or so, 8 to 10 days of fertility exposure does not seem to affect their long-term prognosis. There also appears not to be any delay in their initiation of chemotherapy. If you have somebody that goes through fertility preservation, there was a nice study that was published in Human Reproduction 3 years ago, and it showed that the average time frame for start of chemotherapy was 38 days in someone that did fertility preservation in 39 days in somebody that did not. So it doesn't seem that if you're referring these patients and they're motivated about freezing eggs, that they should not delay the start of their chemotherapy significantly. Pregnancy timing is important, and this is something I do spend some time counseling patients. I really want someone to wait at least 2 years after a breast cancer diagnosis prior to entertaining, even thinking about the option of getting pregnant, and in some cases even longer. There does seem to be some increased risk prior to 2 years, and we don't know, is that a survivorship benefit that the women that waited longer tended to be the healthier cohort, and they had lower recurrence risks and cause of death. But even when trying to control for a healthy woman bias, there does seem to be this time frame after 2 years where it's beneficial. I am putting up just a citation here regarding this Canadian study that showed that there was no increased risk of breast cancer recurrence for women that waited more than 6 months. But why I've included this is I find that this was not a very well-designed study. There was only 112 women that actually had breast cancer that were, and subsequent pregnancies that were included in the study. And so I have this here just saying that this is not something that I've changed my practice modality or recommendations on. I still adhere to the 2-year time frame. And we can discuss this in the Q&A if there's any further questions. So some of the unanswered questions, really where we've got some great research opportunities is what is the safety window for pregnancy or gamete freezing following chemotherapy exposure. This is especially true for men. I get a lot of male referrals that they've already started chemotherapy 2 months ago. Can they now freeze sperm? Well, it takes 72 days for a new cohort of sperm to develop. Is there a sweet spot in terms of less than 72 days? Could there still be some unaffected sperm that's been stored in the epididymis that we could then freeze or not? What are the mechanisms for gonadotropicity? We don't know this. The safety of the immune modulatory drugs, and certainly long-term data is quite sparse. And especially with this increasing utilization of these immune-related drugs, how is this affecting future reproduction and pregnancy? I would like to state that there is some very good accountability as it relates to assisted reproductive technologies, both through the CDC that works in conjunction with SART, the Society for Assisted Reproductive Technology. Any IVF cycle that's been performed in the United States since 1996, we are compelled to report our data to SART and the CDC. They audit and verify these statistics and report publicly live birth rates, miscarriage rates, high order multiple rates. The most recent data that's available is 2018 because it takes about 2 years to compile the data and all those women to have ultimately delivered 9 months later. About just under 2% of children born in the United States are conceived via assisted reproductive techniques. And the number of cycles of oocyte cryopreservation is increasing rapidly. This is either for elective purposes or certainly for cancer-related purposes. How we've implemented our Oncofertility program and counseling at MD Anderson is for our female patients. A referral is sent to our scheduling team and an email goes to our Oncofertility service. And our goal is to get a consult available for a patient, certainly no later than 72 hours after submission. We order ovarian reserve testing in nearly all patients. There are a few exceptions, AMH, antral follicle counts, and if they desire cryopreservation, we email their care team about a 2-week delay. We register the patient with Fertile Hope, which is a nonprofit organization that helps defray some of the costs associated with egg freezing. And if they're a candidate for ovarian suppression, we will email the team to exclude that there's any contraindications and then submit the order for Lupron therapy. There's very few contraindications. One of the more common ones that we run across is especially for some CNS tumors, there is potentially use of Lupron altering the seizure threshold. And so there are some of our neurosurgery and neurology colleagues that would prefer that we not use Lupron in those patients. Depending on the amount of time that I have, I'll discuss what the reproductive impact and options. This is the primary purpose of the referral, but I also spend time discussing contraception. I absolutely don't want them conceiving during their treatment, and I'm always surprised at how few patients really give much consideration to this. Pregnancy timing is something I discuss, and also what to expect should they go into premature ovarian insufficiency or early menopause, and how we can manage them long-term in terms of a bone health and hormone side effect standpoint. For the male patients, same thing. They get a referral electronically, an email to Oncofertility. We try to get them in quickly. And we work with both Baylor College of Medicine and the local Fairfax Cryobank. So we have two options for them. And then we follow up with the patient regarding what their quality, their QC on their sperm cryopreservation, you know, if it was a good sample, if it wasn't, how many vials of sperm were able to be cryopreserved from that sample. We, unlike you, you have a very motivated urologist that's interested in male fertility and fertility preservation. Akanksha Mehta is outstanding, and she really does a great job counseling those patients there in Atlanta. In Houston, we don't have someone on site at MD Anderson that has quite the same interest as Dr. Mehta. So I would just, you know, underscore what a great resource she is for you there in Atlanta. Some of the patient information tools that we have, my colleague Terry Woodard has developed an online pathway analysis. Basically, it's a decision aid for patients to help decide if they're interested in fertility preservation or not. And it's a really great educational tool. And we're hoping to launch this soon, and not just at our institution, but nationally. I have developed lots of resources for patients in terms of patient education materials that we have available at our patient education library online. I'm happy to share any or all of these patient-specific education materials with you. And what we've recently done is launched, it's actually in process now, set to launch this end of this month, but this is a best practice advisory that we've incorporated through our electronic medical record, that any reproductive aged patient that's seen at MD Anderson, there will be a flag in the electronic medical record stating that consider giving them, submitting an oncofertility referral. And the patient, and then the provider has the option of either saying this is not applicable for this patient, the patient declines, I'm not the appropriate provider, or they can launch a referral and order the consult. For patients between ages 14 and 17, they're going to our AYA program, and then for patients 18 to 43, they would go to my oncofertility program. But there is a significant overlap between the two programs, and we work very well and closely together. So just something that you may want to consider potentially implementing so that these patients don't fall through the cracks and you're in good compliance with the ASCO guidelines. You also have a great resource too through your EMR. Your REI program developed an Emmy, which is basically a video, educational video for patients that you can actually order. It's MEEMMI, Oncofertility. And if you search it under orders and you click on it, it will send an educational video to your patient regarding oncofertility options there in Atlanta. Some of the organizations I recommend to patients: Livestrong, myoncofertility.org, and resolve.org. These are three great organizations that are very patient-centric and do a good job with your patients in terms of helping them cope from a psychosocial standpoint with their, not just their diagnosis, but also the reproductive impact. Some of the challenges that we encounter in terms of our oncofertility services is we're embedded in GYN oncology, but we're a hospital-wide service. And then how do you audit your outreach, and are you doing a good job in terms of capturing the entire reproductive age population at your institution? Cost is challenging for patients, especially in such a limited time frame. If someone has to freeze ASAP, how are they going to come up with the $6,000 to $8,000 to $10,000 to do egg freezing? And certainly that number can drop significantly if they're working with Fertile Hope, and Walgreens also has a program where they'll help cover the cost of these medications, but it's still expensive. Should they be freezing eggs or embryos? That's an important decision to be made, and has some bearing in terms of if they've got an inherited cancer syndrome and preimplantation genetic testing is needed. What if the patient has already started chemotherapy? What is your institutional policy, and do you have appropriate consents in terms of could there be some increased risk of teratogenicity in that offspring? And then how do you implement, and have you implemented, ovarian tissue freezing at your institution? And certainly this is a collaborative effort. It's a team effort with GYN oncology, pediatric adolescent gynecology, and you have a great PAG person there, as well as general surgery. And the chain of custody for that tissue, if you freeze ovarian tissue, if you do an oophorectomy there at Winship or at CHOA, how is that tissue getting transported to the IVF lab, which may not be, it is not on site, it's over at Midtown, for example. And we run into that same issue too. We are doing the oophorectomies here at MD Anderson, but then the tissue is not being frozen here, it's being frozen across the street at Texas Children's and the Family Fertility Center there. So again, just lots of logistical considerations. And so the take-home points I would like to make is that this is important to your patients. Please offer an early referral and provide patient information. Communicate to your fertility specialist any of the concerns you have, especially it pertains to stimulation. Review the options for patients as well as the alternatives. We focused a lot on discussion just for time purposes with their own gametes, but there are lots of options for family building: donor embryos, donor oocytes, gestational carriers, child adoption. There's lots of paths for family building. And just in the interest of time, I've been focusing just on someone's own oocytes. Consider a baseline assessment of ovarian reserve for your patients, and please provide the emotional support and resources for them. Keep in mind, when you refer a patient to me or to your Oncofertility team, you are sending a message to that patient that you expect that they're going to survive and that they're going to have the option to make these decisions about family building and fertility use of these preserved oocytes down the future. And I will say, of the patients that I see, only about half decide to do fertility preservation, and that's fine because there's really good data to show just having that conversation is helpful for the patient in terms of long-term regret after completion of cancer treatment. And so the hope that you're instilling, the fact that you're allowing the patient to be making the decision, and this decision isn't being made for her or for him, is very empowering. And I think it's exceedingly important from a long-term psychosocial standpoint. So I'd like to close with that and open for some questions. I believe Julie is going to be monitoring some of the typed questions through the Q&A. And also I'm available offline anytime to talk about this or these questions. Julie has my contact information. You're also welcome to reach me by phone. My cell phone is readily available, as is my email, at any time. And so thank you so much for your attention, especially this early in the morning. I hope you have your coffee, and again, thank you for having me.
Thanks, Dr. McKenzie. If you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, please plan to tune in next week, as our Grand Round speaker will be Dr. Lisa Baumann-Kruziger, who will be presenting From Catheters to VADS, Understanding Device-Related Thrombosis. To view all upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website and the Winship calendar. I know there's a couple that have populated, and there's also one in the chat.
Okay, I'm looking, just give me a moment here.
Yeah.
The font is small. So. So it looks like there's a question. It says, what pieces of your ART and FP counseling would differ both before treatment and after treatment for female liquid cancer patients or liquid cancer survivors as opposed to solid tumor patients? And what have the outcome differences been? Really not a significant difference in terms of if you're referring to survivorship or if you're referring to how do I manage these patients. If I have someone that's exceedingly ill right at the time of presentation, you know, I have some patients, if their platelet counts are significantly down, they're very sick at the time that I'm seeing them. Sometimes that will be a contraindication just in and of itself to proceeding with any type of fertility preservation. Even if their platelet counts are adequate by what we would consider surgical criteria, they seem to be significantly dysfunctional and have increased risk for bleeding. Those are patients I tend to be more aggressive as well in terms of menstrual suppression. And we have an algorithm that we use for these patients. If I'm particularly worried about bleeding, I will overlap with birth control pills for about 2 to 3 weeks while I'm waiting for the Lupron to kick in, just to help avoid any significant vaginal bleeding risks in that patient. I'm hoping that that's what you're asking in terms of the question, and forgive me if I'm not answering that appropriately. Yeah, we found, just kind of as an aside, if we're waiting for any other questions, we found in the justification for us launching this best practice advisory through our EPIC was we were capturing less than 10% of our reproductive age patients. And so it's a little bit of a shame on us that we were not capturing a larger cohort of these patients. And so we're really making an effort to improve our counseling and outreach to that reproductive aged group. And so hopefully in a year's time, we've got metrics set up to be able to track what's going on with this group of patients and make sure that our interventions are working appropriately in terms of identification and counseling.
So there are 3 questions in the Q&A box. Mm-hmm.
Yeah, so a great question. There's a question from Martha regarding tyrosine kinase inhibitors. And if you look at the package insert, it's very modest. It says avoid pregnancy during use of tyrosine kinase inhibitors. And I think it says 2 to 3 weeks after completion. When I counsel patients, I say that, you know, obviously the standard disclaimer that there's very, very little data with these patients. But long-term, I'll just tell you anecdotally, I don't see significant fertility compromise in these patients. And granted, I don't have 10 years of data, but I would say 3 to 5 years out, I personally have not noticed a significant drop in fertility with these patients that are exposed to either monoclonal antibodies or tyrosine kinase inhibitors, which I think is really interesting. This is very different compared to like the dose-dense regimens that I'm seeing with breast cancer patients. We've got an abstract being presented this year with a little over 30% of those patients where normally you would see a less than 20% long-term or premature ovarian insufficiency rate developing POI in those patients, so a much higher population with the dose-dense protocols. And so Lillian asked a question here, the challenges of post-therapy fertility preservation, but what is our standard of practice for men and women who desire fertility preservation after the start of gonadotoxic toxic cancer therapy? So that's something I alluded to just very briefly in my talk, but it's a big concern for us. Historically, MD Anderson was pretty hard line in terms of not offering FERT-Pres for patients that had recent chemotherapy exposure. For example, if there was a male patient that had been who had already started chemotherapy for leukemia 2 months ago, he would not be allowed to cryopreserve sperm. That has changed, and there's actually now a consenting process and counseling that we say, look, we really don't know, but if you're getting ready to undergo stem cell transplantation, this is your only option. We'll freeze with the understanding and the caveat that hopefully there'll be some testing that can be used down the line to help assess the quality of the sperm. There are ways to do FISH analysis, genetic testing on the sperm, but it's very limited currently. It involves only about 5 different chromosomes commercially. This is what's clinically available now. And so DNA fragmentation assays have been utilized, but really we don't know. We actually have a study in progress looking at, a much more in-depth genetic assessment of sperm in men that had been exposed to chemotherapy and at different time frames. Let's talk about, there's a question regarding state-sponsored programs for the coverage of retrieval and storage. Yeah, there are states, there's about 7 states that have mandated fertility coverage in the United States, and about 11 that will cover if it's related to a cancer diagnosis. So we have a long way to go in terms of universal coverage for cancer patients, and this is really a problem. There's different organizations, as I mentioned, Fertile Hope, and then also Walgreens will help cover the cost of these medications. Locally, you have the option too of an organization called Team Maggie, and that they help provide grants for young women that need to help augment the cost for fertility preservation, specifically egg freezing. But a lot that remains unanswered is who's going to be covering the cost for ovarian tissue freezing now that it's not considered experimental. Is insurance going to cover this? What is going to be the direct cost for the patient? And that's very much institution dependent because this is new. There are some institutions that are waiving any associated costs. Some are charging the patients a marginal fee of about $600 and doing a unilateral oophorectomy at the time of port placement. So it's, there's a ways to go in terms of that. So there's a question about medication cost, but also storage cost precludes doing this. Yeah, unfortunately with the Grady population too, that's a big challenge. And then ovarian suppression, Lupron administration is the only choice that those patients have. And that's really kind of highlighting one of the big health disparities that we see, sadly, among fertility preservation. When we look at the demographics of who's freezing eggs, who's freezing embryos, it correlates very much with the income status of the individual, which I think is really egregious, and nobody should be turned away from egg freezing related to cost, particularly if you're talking about an individual with a cancer diagnosis. And that's really just one of the social injustices that we are encountering. And so I think there's a question about hormone or endocrine therapy for a patient. I'm hoping I'm reading this correctly. So if I have a patient that's on long-term endocrine therapy, obviously we would have a discussion in concert with their care team. But if they're going to take a drug holiday, the earliest I typically would recommend that would be after 2 years of tamoxifen or an aromatase inhibitor. And then we really counsel the patient that they need to aggressively pursue fertility. I don't want them off their hormone suppression for any significant amount of time. Depending on what agents they're exposed to, if it's a tyrosine kinase inhibitor, I'm certainly less concerned than if they were, on methotrexate therapy, for example, where the recommendation is a minimum of 3 months, and some will say even a little bit longer. There's a question about prevalence of ovarian tissue cryopreservation in the Houston area. MD Anderson it's still limited for us. We have not been doing a lot of ovarian tissue freezing. I mean, we haven't had any patients that have used that tissue subsequently. They haven't retransplanted that tissue. We still have it under the auspices of an IRB. We're still enrolling patients in an IRB for this. And you are unique in there in Atlanta. You have a great team in the REI division there. Jessica Spencer, Jennifer Kloss, Heather Hip. You've got a really good team that's sensitive to these patients. And that doesn't exist everywhere because timing is key. You need these patients in quickly. And fortunately, the folks that you have there at Emory understand that. And you also have someone that's very motivated from the male side as well. So you're kind of sitting pretty in terms of that. And then, you know, just something that is not available at every institution.
Well, thank you so much, Dr. McKenzie, for your time today. We really appreciate it, and we look forward to bringing you back at some point in the future.
Great. Well, thanks again for your attention. And as I mentioned, Julie has my contact information. I'd be happy to go through logistics or how we've worked on our program here. You know, our institution is very forthcoming, at least as it pertains to our oncofertility programming. We're happy to share any and all of our findings. So, all right. Well, have a great day. Thanks again, Julie. Bye-bye.